Welcome, everybody. My name is Dr. Dan Bruns. I am the chair of the Pain Psychology Interest Group, which is part of the Society for Health Psychology. Thank you for joining us today for our first pain webinar. This webinar is hosted by the Society for Health Psychology, the Pain Psychology Interest Group, and is co-sponsored by the Society for Clinical Psychology, APA Division 12. We're planning a series of pain psychology webinars, and we hope you'll find all of them interesting and useful as well. I'm especially excited today about our first pain psychology webinar, which is entitled Novel Psychological Treatments for Chronic Pain. To begin, though, we have a few announcements to share, and for this, I defer to the Associate Chair of the Pain Interest Group, Dr. Maya Bruzas.
Hi, I'm Dr. Maya Bruzas, Associate Chair of the APA's Pain Psychology Special Interest Group. Before we begin, I have just a few things to share. This event will be recorded, so anyone who speaks during it is agreeing to be recorded and is granting permission for the recording to be posted on the website. We are anticipating approximately 300 attendees, so we will not be opening things up to open questions and answers at the end. Dr. Bruns and I will ask Dr. Lumley several questions after his presentation. The webinar is also eligible for one continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. CE evaluation information will be sent via email shortly after the webinar. We will leave the evaluation open until Friday, September 20th at 5 p.m. Eastern. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. And now I will turn it over to Dr. Bruns.
Thank you, Maya. When we were planning these webinars, we considered a wide variety of topics and possible speakers. And after thinking about this a lot, we thought, who would be a better lead-off speaker than Dr. Mark Lumley? Dr. Lumley is a distinguished professor at Wayne State University in Detroit, and his career and research have been, in my opinion, remarkable. For decades, as you know, the dominant model in the field has been cognitive behavioral interventions for pain. And to a substantial extent, though, these methods involve affective control or suppression. And after all, it has origins in Stoic philosophy. But Dr. Lumley took an entirely different approach to the problem of chronic pain. And over the course of 33 years, he published over 120 articles and wrote book chapters on the relationship between pain and unexpressed emotion. This eventually led him to develop new methods of psychological treatments for pain based on facilitating the expression of these emotions. Dr. Lumley has already won multiple national awards for his work, and beyond being, in my opinion, a brilliant theorist and researcher, Mark is also a kind and an approachable person, and not surprisingly, one of his national awards is for being a mentor. Now, spoiler alert, in a couple of weeks, Dr. Lumley will receive the Nathan Perry Career Service Award for his work on chronic pain. As you probably know, this is the most prestigious of all health psychology awards. So congratulations, Mark. So it's my great pleasure to introduce the speaker for our first pain psychology webinar, Dr. Mark Lumley. Take it away, Mark.
Thank you so much there, Dan. My goodness, now I have to live up to that, don't I? I'll share my screen in just a moment. I'm sitting here watching the number at the bottom increase up to 132 of us. So this is quite a crowd. I'm told by Barbara Keaton that 279 people had registered, and many people were wanting to join this event, and she's making sure they join our society and pay the dues before they do so. So this could be a great way to also advertise and increase our membership as well. Let me see, I'll share a screen here. Hopefully that's all easy enough for you to see. I want to start by offering up what might be a trigger warning. I'm never sure if trigger warnings actually work, so let me just give you a heads up. The older I've gotten, the more I've been willing to push the boundaries and to press back on some of our traditions in our field. And the result is that I'm going to present some stuff today that will create a mixture of emotions in you, I suspect. Some of you, many of you, I hope, will feel relief, gratitude, excitement about these new directions. But I also suspect that some of you will have mixed emotions, including anger, because I'm going to probably pick on some of the things that you've devoted yourselves to or that you do regularly that you believe in. By the way, anger is a good emotion, so it's okay by me if you have it, and I can even handle it if you want to express it, along with the other emotions, which we'll come back to, the expression of emotions. As I put this presentation together today, I've been working hard at reducing the number of slides because I have a slide deck in PowerPoint that's like 300 slides long, and I've been trying to weed them out so I can squeeze it in so we can end up at about 10 minutes before the top of the hour. I'm keeping an eye on the clock, and if I start to go too long on things, I'll probably move more quickly through the slides. My apologies in advance for the sin of probably trying to cover too much. All right, so I want to start actually by celebrating what our field has contributed, not challenging it, but celebrating it. Our field, health psychology, pain psychology, and other fields, including, I'm sure many people in this audience, have made a lot of contributions. I think one of the major ones is shifting us from a simple biomedical model that tissue damage, like this classic picture that Descartes had, that tissue damage simply leads to pain in a unidirectional way. And we've replaced that with a more complex biopsychosocial model, which puts pain at the nexus of these multiple different factors, a model that all of us, I'm sure, recognize. Here's another contribution. We have helped the field shift from reliance solely on medical treatments, like surgeries and such, with their high cost and side effects and their limited efficacy for many people with chronic pain, to behavioral and psychological interventions. I think we need to pause and celebrate these successes. Here's another contribution. We have worked to help shift patients from desperately and unsuccessfully seeking to eliminate their pain, which has so often led to hopelessness and depression and anger, to a chronic pain model in which we say, we can help you adapt to or cope with or manage or accept or live with your pain. Okay, actually, I want to challenge this idea completely. This is one that I want to move towards challenging and talk about other ways of viewing pain. So if I were to ask you, and I would invite you to speak out loud, but not through your microphone, we're going to keep everybody muted. What are the top psychological interventions right now for chronic pain? You can say it out loud. Okay, I heard somebody say CBT. Oh, that's the number one, always comes up. A number of you said ACT, mindfulness approaches. These three are probably the most studied and perhaps practiced approaches in chronic pain by psychologists, at least in our country. And if I were to take a look at CBT in particular and ask the question, is it effective for chronic pain? You'd probably do like, duh, of course it's effective. And of course it is, right? It's empirically supported and evidence-based. Lots of randomized controlled trials have tested it. Bunches of meta-analyses have confirmed its efficacy. It's in all the treatment guidelines. But let me ask a different question. Isn't there a more important question than is something effective for chronic pain? You might ask questions like, for whom does it work? The moderator question, or how does it work? The mediator question, or on what outcomes does it work? Or for how long does it work? Or how do we disseminate it more? Valuable questions, but for me, the most important question is this: how effective is it? Side note, what efficacy usually means is it's reliably not zero. And reliably not zero is not too exciting to me. I want to know, how effective is something? How many people will be helped and how much? And for that, I want to turn to this wonderful Cochrane review by Amanda Williams and company, published in 2020, in which they reviewed the literature on basically the best trials in CBT. Large trials, had a minimum number of participants. They also did it for ACT and for behavior therapy, but I want to focus on CBT. And here's what the data came out of from that Cochrane review. In randomized clinical trials, controlled trials, when you compare CBT to treatment as usual or waiting list, and you can see some almost 30 trials, the outcomes of pain reduction, disability reduction, and distress reduction had these standardized mean differences, or D values, at post-treatment, at 6-month or longer follow-up. And by the way, if you compare CBT to active controls, maybe you give the controls basic education or some support or something, you can see the effect sizes there. Now, how many of you speak D or SMD? Well, the truth is, this is a sophisticated audience. You actually might understand these things. You can even see curves in your head and where cutoffs are and that sort of thing. But I don't know many patients who would speak this language. So let me translate this Cochrane review to patient doctor language, plain language. Imagine a patient says to you, hey, doc, how much more will my pain improve after CBT than after my usual care? And here is your empirically supported, evidence-based answer. On a 0 to 10 scale, you tell your patient, the average patient's pain improves about this many more points. Make sure you all turn your microphones off, and I believe Barbara Keaton is on that thing as well to keep people muted. Thanks. So your answer to the patient would be on a 0 to 10 scale, the average patient's pain improves about this many more points after CBT than after usual care. I wonder what number you would put in there. 3 more points, 4 more points, 2 more points on a 0 to 10 scale after CBT compared to usual care? Drum roll, please. 0.4 of a point for post-treatment. For pain reduction, if you look at the other 2 major outcomes, functioning disability, about 0.6 of a point, psychological distress, 0.7 of a point. If you go out 6 months plus, the effect is smaller, about 2.2 of 1 point on the 0 to 10 scale. And by the way, if you're curious, I'm basing this on the standard deviation of about a 2.0 on a 10-point scale. I don't know about you, but I don't know that I want to tell my patients that. I'm not too excited about that. It raises the question, why are these effects so small? Is it possible, for example, that these RCTs underestimate the effect size? I got to confess something. I just pulled a fast one on you. How many patients would ask you, how much better will I get if I do CBT than if I do my usual care? No patients ask questions like that. They ask a different question, right? How much better will I be later after CBT than I am right now? That's a within-person change. This is a disconnect between our randomized clinical trials where we're interested in what's happening in a therapy compared to something else and what happens clinically where patients want to know how much better will I get from now to later after doing an intervention. The within-person change in CBT is larger. Basically double those numbers I gave you. It's closer to a 1-point reduction on the 10-point scale for pain and a 1.2 reduction for disability. But about half of that reduction would have occurred anyway without CBT. Some people say RCTs might not generalize well. Maybe the therapists aren't well trained. Maybe the patients are too, maybe they're not struggling with pain enough. They're not like real clinic patients. Some people have argued, well, maybe chronic pain is just mostly controlled by biology and not by psychological processes. My answer to that is, I don't think so. Some have said, maybe we've done all that we can clinically as psychologists to improve chronic pain, and we've reached the limit of our abilities, and I doubt that. Here's what I think. I think that there are a set of problematic assumptions that limit the effectiveness of these traditional approaches. By the way, I should add that meta-analyses on ACT and mindfulness-based approaches basically show about the same size as CBT. ACT might do a little better on functioning because it really strives for that, and a little weaker on pain reduction because it doesn't strive for that. But mostly it's not that strong either. So I'm going to go over some of these assumptions. As we go along, I'll share a little data, talk about some approaches that we're using. Problematic assumption number 1, and I wonder how many of you have used this phrase, pain is pain. I hear that a lot from pain psychologists. It ignores the etiology and basically says we can treat all pain the same. But there are different types of pain, and it may matter. The ICD-11, with the support of the International Association for the Study of Pain, has got a diagnostic system now that divides chronic pain into primary and secondary. The primary pain, like on the left here, are those types of pain where the pain itself is the problem. It's sort of the disease entity to be targeted. It's not due necessarily or clearly to some underlying pathology or disease or structural problem. Whereas the secondary pain on the right is due to anoxia, tumors, inflammation, neuropathic processes, and other sorts of things. What's important to me about this is that if you look at the primary pain category, which by the way is a really large category of people, most people with back pain, almost everybody with fibromyalgia, headache pain, and the like, are going to have primary pain. That's the most that we're going to see. This type of pain is more driven by central nervous system, brain, mind, psychosocial processes. By the way, terms nociplastic or neuroplastic are also used to describe this type of pain. Whereas secondary pain is more driven by peripheral processes and structural processes. So terms like nociceptive and neuropathic. describe the mechanisms of this type of pain. In our work, we've been focusing on primary pain and not on secondary pain. We'll come back to that. Here's another assumption that I think is problematic, that chronic pain primarily comes from damaged tissues. But actually, there's a very weak link between the experience and the report of pain and any sort of imaging or lab findings. What's the typical correlation coefficient between measures of disease or pathology or pathophysiology of the body and experienced pain? You're lucky if you can get an R of 0.2. It's pretty weak. Here's one of my favorite slides. We actually show this to patients in our studies. This is an assembly of number of studies that did spinal imaging of people who did not have pain. These are healthy controls, if you like, pain-free, asymptomatic people across the age spectrum. And you can see these various imaging findings on the left. They increase in prevalence to the right. So Dan Bruns, you're a young guy. You're probably 40 or 50 years old, right? So, what's the chance that Dan has, I don't know, disc bulging? Even if he's pain-free, I'm not sure if he's pain-free or not, but if you were pain-free, his disc bulging would still be 50 or 60% as a young man. Old guy like me, there's a big chance that I've got something going. I don't have back pain or neck pain, but there's, if you put me in a scanner, you'll find something. What's the moral of the story? If I start to develop pain and I go and get scanned, are they going to find something wrong with my back? Yup. Are they going to say this is the likely cause? Am I going to start to believe that it's the pathology in my back that's causing the pain? Quite likely. So that we use this to remind patients that just because they've got that bulging disc, for example, doesn't mean that's the cause of their pain. Here's the third assumption that I think is problematic. How many of you have used that term modulate? Like the brain, the mind, psychology modulates pain from the body. I hear that term a lot. I'd like to suggest that we need to do more than that. Not just modulate, but the brain can actually generate, and flip side, it can substantially reduce or eliminate pain. So let me do a little tangent for a couple of slides here. What's the role of the brain in pain? Most of the field would accept this premise, that the brain, or if you like, the psychosocial, cognitive, emotional processes in the brain, can increase a person's pain by, for example, increasing their muscle tension or disrupting their sleep. Lots of good evidence that sleep disruption increases pain. Can disrupt autonomic nervous system functioning, and there might be some links to that with pain. There's some evidence that it can even, that brain-based psychosocial factors can modify peripheral inflammation, which might contribute to autoimmune diseases and pain, for example. Most of the field agrees that the brain can do this through the periphery, usually. Here's another thing that's accepted, that the brain has some capacity to modulate, if you like, or gate the pain sensation. Things descend from the brain, and it can control the attention, the mood, the appraisal, et cetera, can influence the ascending nociception from the body. But notice again, the body seems to be the driver of the pain, and the brain has some capacity to do something with it. But I'm going to take this further. I think we should argue that the brain can actually generate pain in the absence of meaningful peripheral nociception. Here's a few examples. Phantom limb pain, though there's some debate as to whether the damaged nerves at the root might be doing something, but most people believe the brain has got an image of the missing limb and can still experience pain out in that missing limb. Conditioned pain. Quick story. We have a woman in our clinical trial right now who she's in there for back and neck pain, but she also reported she sometimes feels pain in her cheekbone. What happened? She said, well, my husband punched me and broke my orbital bone. It caused a lot of pain. The pain finally went away, as did my husband. But now when I see my ex, I feel pain right here again. Classically conditioned, if you like. Some people experience empathic pain. When they see another person in pain, they experience it in their own body. If you haven't seen the rubber hand illusion, you can do a quick YouTube search. There's some great demonstrations of what happens when the brain believes that this rubber arm out here is their own arm. And if it's punctured or smashed, the person experiences pain, even though it's not their real hand. It's a fascinating demonstration. We also show that to our patients. And finally, the visualization of pain eliciting behavior is a technique we use all the time. I would invite you to invite your patients or even yourself to simply sit comfortably as you can and visualize as vividly as you can a pain-inducing behavior, bending, twisting, whatever. We're finding about 60% of patients will report experiencing pain in the process of visualizing movement. We can do the flip side too. We can give them some language to practice that says they're safe, their back is not damaged, the brain is giving a message, and that actually will reduce the pain while they're imagining doing some of these behaviors. So the conclusion I would make is that the brain has the potential to eliminate pain, at least in many people. And here's a few examples where we do know that the brain has this capacity. Some people with hypnotic analgesia, many people who have a phantom limb and experience the mirror box phenomenon will experience their pain disappearing in that missing limb. There's some evidence coming out of virtual reality of the body doing pain-free activities, and for some people it leads to a pain just disappearing while they're doing the activity. And the newer therapies that I want to talk about today. But wait, Mark, you might say, maybe you've said this. Pain is chronic. It's intractable. It doesn't remit. And there's lots of people who say that, right? So, by the way, when I asked some clinical trial colleagues of mine, I asked one who's quite famous, who had run a CBT trial with hundreds of participants. And I asked this person, how many of your people had pain elimination? And the person went back and looked at their data set and said, 3 out of hundreds and hundreds in the trial. When I ask clinicians, they'll say, I don't see my patients recovering from pain. They don't recover from it. They still always have pain. I would ask you, is there a logical fallacy here? Probably has some Latin phrase that ipso facto ergo post hoc, something, I don't know. But if you do X and Y does not occur, therefore Y cannot occur. Let me give it to you differently. I cannot get this nail to go all the way through the board. Therefore, nails don't go through boards. I don't see microbes. Therefore, microbes don't exist. You get the moral. You're all sharp folks, right? Maybe we're using the wrong tool. So here's a newer model. This is the model we've been using in our work. The brain is the pain. It generates the perception of pain based on predictive processing. The predictive processing involves some or not sensation from the body, but it certainly includes fears, beliefs, social examples, messages like, look at that bad disc, it must be the cause. The brain puts together a perception and creates this thing called pain based on its predictions. And the predictions are about what's happening to the body or how much danger a person's in. So think of acute pain. If you stand up right now and smash your knee on your desk, or you twist your ankle walking out the door, and you feel some acute pain, thankfully, you will feel acute pain. You can think of that as the brain's system to detect damage to the body. It's an alarm the brain has, this pain it creates. But what about chronic pain? Here the brain has shifted, I think, from I pick up damage to the body to a more general detection of danger. A danger detection alarm is what pain is in chronic pain. It could pick up danger that the body might be in danger from injury, from movement, physical danger from assault. And also, I would argue, psychosocial or emotional danger, such as might happen with people who've been rejected, or victimized, or oppressed. Chronic pain is the brain's system of identifying danger, and it gets activated when it experiences danger of various sorts. So pain reprocessing therapy is the first I want to talk about as the 2 novel therapies I'll talk about today, and I'll give this brief attention. I was part of the group that developed this. A number of us were working together, and then our work sort of split off into focusing on pain and focusing on emotions. And this is the focus on pain. Pain reprocessing therapy tries to create learning experiences to help patients see that their primary pain or neuroplastic pain is based on brain expectations and fears, not bodily damage. To help the patient shift from, I think I have a damaged body, to this pain is in my brain, from my brain. It is my brain talking. And to turn off the so-called false alarm of bodily damage in the brain's construction of pain. So in a simple diagram, I think of pain reprocessing as including a lot of pain neuroscience education, this most recent understanding of the brain and pain, chronic pain specifically. Engage patients in various pain eliciting exercises, whether they're imaginal or behavioral. Then engage in mindful somatic tracking. That's sort of borrowed quite a bit from mindfulness of what their experience is bodily. And instead of trying to reduce it or be fearful of it, there's some distancing taken from it and some curiosity. And many patients will start to experience their body differently in this process. And it becomes clearer to them that what's happening is something about their brain over their body rather than just a broken body. Add in some cognitive affirmations of health, like helping to remind the self that this is my brain talking, this is not a damaged back or knee or whatever. My body is safe. It's false alarm. And a little bit of work, a cognitive work, usually on stress-inducing beliefs like I have to be perfect or something like that, or I worry a lot. It doesn't do much with emotion, mostly focuses on pain and the body and movement and the cognitions connecting these things. The big study that was done at the University of Boulder, Colorado, a couple of years back. It's published in 2022 in the journal JAMA Psychiatry. This study took 150 patients with back pain and randomized them to one of three arms: pain reprocessing therapy. And importantly, this was done with one session remotely with a physician who confirmed primary pain and gave a bit of a pain message about, from a physician's perspective, of where it's coming from. Then 8 sessions individually with a therapist over the course of 4 weeks, twice a week for 4 weeks. And they was compared in this study to an open label placebo injection. There's a backstory about why that's there. I don't want to get into it today, but we all recognize it's not the best control for a psychological intervention, but also treatment as usual, which is the usual control for our psychological interventions. And the question is, what's the average pain severity over the last week? The study also did brain fMRIs pre and post therapy. The team of this included, going clockwise, this is Tor Wager's lab at the University of Colorado Boulder. Tor's since moved to Dartmouth. And this was his doctoral student, Yoni Yashar, who's now graduated and on the faculty at the University of Denver, Colorado. Howard Schubiner, my longtime colleague, was the physician who met with all these patients and gave the message about, this is your brain and I'm a physician and I've looked at your MRIs and here's what here's what I believe is going on. These two folks, Alan Gordon and Christy Weepy, were the 2 therapists in the study. 2 of the best therapists I've ever met. Both of them are social workers, by the way. Yours truly joined the team as sort of a research consultant on it. What was found in this study? Here's the pain severity over the last week from baseline through the end of treatment and out to a year. Much, much greater, significantly for sure, but also magnitudes greater reduction in pain compared to both of the control groups. Here's another way of looking at the data, these teardrop or violin graphs. Looking at usual care, the folks on the 0 line had a 0% reduction in their pain. Most of them stayed the same. Some of them got a little worse. Some of them got a little better. A few got quite a bit better. But on average, it was just a little bit of improvement. Jumping over to PRT, nobody had a worsening of their pain. One person had 0 change. Look at all these people down on the 100% reduction line. These are all cases. Had 100% reduction of their pain, which means 0. And a number of other people had substantial reductions. The number of people, we actually had to create a new category for this. Most of the pain research uses metrics like 30% reduction in pain from baseline, or maybe 50% if you're lucky. In this trial, we created one called pain-free or nearly pain-free, a score of 1 or less on the 0 to 10 pain scale. And you can see that about 2/3 of the PRT patients were pain-free or nearly pain-free at post-treatment. A little bit of loss going out to a 12-month follow-up, but still much greater than, for example, treatment as usual. These are the effect sizes. Post-treatment, 1 3/4 standard deviation, a little over 1 standard deviation a year later. You remember the effect sizes from CBT in that Cochrane review? Those were 0.2, 0.3. And if you're curious, for the neuroscientists out there, the fMRI showed some changes in these regions, which are often implicated in pain chronicity from pre to post pain reprocessing therapy. So what do I think about pain reprocessing therapy? A few thoughts about it. First off, I think this trial was a powerful demonstration that some people, maybe many people, can recover, can have substantial pain reduction or even pain elimination. I think pain reprocessing therapy has some unique components. It gives a strong message about where the pain is coming from and where it's not coming from. It has a number of creative techniques to help elicit pain and reinterpret it and reduce the fears surrounding bodily injury, bodily damage, and fear of pain. However, we need to be thoughtful and circumspect about this and cautious. This trial had an initial physician session, and Howard Schubiner is one of the best in the world at doing this sort of work in this mind-body pain space. This physician confirmed the primary pain and sort of diagnosed it as mind-body, which I think really helped. These were expert therapists, both of whom, Alan and Christy, both of whom had recovered from their own pain problem, which I think motivates creates an aura, creates a message that really allows people to be more convincing in their work. Best, by the way, probably the two best therapists I've ever seen do this work. The participants were from Boulder, Colorado, motivated, mostly stable psychologically, economically, almost all white. And this was done in a university setting, which included MRIs of the brain before and after, which I think might create an idea that the brain's really important. How would this play out under other conditions in your pain clinic or some other place where people are lined up for surgery or injections or whatnot? We don't know. We're testing it right now with Yoni Ashar taking the lead on several trials with other therapists, more basic populations, community populations of other sorts, clinic populations. And so we'll see what goes on with that. And we're also comparing it to CBT in some of these other trials. So here's another problematic assumption number 4 of these CBT, ACT, mindfulness, these leading interventions, that we don't need to target psychological trauma or conflict. But I would say that these things drive and maintain pain for many people. Okay. So for example, just a few quick stories. This woman with fibromyalgia said, when I was a girl, my drunk father would come home, beat my mom. I sat frozen in fear in the other room. This woman with fibromyalgia said, when I was in college, I was on a date. He raped me in his car. And to make matters worse, when I told the campus police and then my father, they both said, why were you in his car? Ouch. This guy said, we got ambushed in Iraq. I was injured, but my friend next to me got blown up. These are the sorts of things one might diagnose with PTSD. And I asked the question, what's the overlap of PTSD and primary chronic pain? Maybe a third. Maybe a third of people with chronic primary pain will have the diagnosis of PTSD. It varies by how you diagnose it and where you recruit, especially where you recruit the populations from. But what about these patients? Do these folks have PTSD? Excuse me, this woman said, I'm 50 years old now, but 30 years ago, I got mad at my mother and I told her to shut up. She's always been tough on me. And I made her very mad. Now I watch my mouth and try to avoid her whenever I can. Excuse me for a second while I didn't want to cough in your ears. So she said that. Now I just avoid her. My pain flares whenever I'm around my mom. This young man said, my dad does not accept the fact that I'm gay. Now my pain flares up whenever I'm home for the holidays. This man said, my daughter uses heroin. It humiliates me, but I have to take care of her. I can't be mad at her, can I? She's my daughter. Do these sound like PTSD stories? No, they're not the life-threatening sort of things. What are they? Well, the way I like to think about it is you could call those trauma with a little t. I actually like to think of them as conflict, to borrow an old term, psychological interpersonal conflict. And those things are really common. They cover most of primary pain patients. And here are some examples that we see all the time in people who maybe don't have PTSD, but they still have ruminations and intrusions and arousal and cognitive disruptions and the like. So the fifth issue is that most pain clinicians don't target, this is not the fifth issue, but most pain clinicians, however, do not target these problems, right? And it makes some sense. The negative emotions that are connected with these, anger, guilt, and sadness, those are seen as pathological, like they're positively correlated with pain. They're common responses to pain. We should probably downregulate these emotions, control them, reduce them in some way. They're a problem. But here's the fifth problematic assumption, that uncomfortable emotions need to be downregulated. I'm going to argue, and it's not just me, there's a lot of literature that argues that processing of avoided adaptive emotions is healthy. And by process, I mean experiencing them, labeling them, expressing them, and reflecting upon them. Very briefly, I'll take you through some literatures that suggest that avoiding, suppressing, minimizing, blocking, denying important cognitive emotional experiences is problematic. It's maladaptive. There's a literature on alexithymia or low emotional awareness, and I've contributed to that literature a lot myself that says this. The work on what maintains fear, or Stephen Hayes' work on experiential avoidance, or James Gross's great experimental work on suppressing the expression of your emotions when under some threat. Dan Wegner's work on suppressing your thoughts, or Anita Kelly's work on the little lies we tell in the course of our day, or the work by Slepian or Larson on keeping secrets or self-concealing, like stigmatizing things. Jamie Pennebaker's work on non-disclosing trauma, and even the emotional intelligence folks, it all points in the same direction. There's a value in actually experiencing, expressing, recognizing, processing difficult things rather than avoiding it. By the way, folks, how many of you have had a course in counseling or psychotherapy? That's probably most of you. Which therapy process most strongly predicts the outcomes of therapy? Some of you said the therapeutic alliance or the relationship. I think I heard that. Yep, that's a really common answer. We've all been taught that. If you're not aware of the work that's been done by Division 29, the psychotherapy division, in multiple task forces over 20 some years, they've been reviewing the literature and meta-analyzing the processes of psychotherapy that predict good outcomes, and also characteristics of the patient in which therapy can be tailored to predict the best outcomes. We often know about Division 12's empirically supported treatments thing they've been doing for years. This is a parallel, complementary piece that many of us don't know about. John Norcross, Mike Lambert, Bruce Wampold have been leading the charge. And this is from the most recent 2018 publication. And you'll see here that, sure enough, the alliance in individual therapy has a correlation of 0.28 with good outcomes. There it is. But check it out. Emotional expression has a stronger association with good outcomes. Patients who are viewed as expressing emotions during therapy sessions have better outcomes, and this is a substantial effect. It's probably effective rather than demonstrably because it's not been studied as much, and there's lots of different ways to code emotional expression, so it's not as clear. But for me, this is really important. Many of us want to keep sessions calm, composed, and regulated, but maybe emotional expression from patients would be a more powerful predictor benefit to outcomes. It raises another question: what emotions do we need to target? I'm looking at the clock, so I'm going to pick it up a little bit here. There's two major dimensions, motivations that we humans have. One is relatedness and communion, and the other is autonomy and independence. These things are from a number of theories. Additionally, you could also say that there's competent self, which comes from self-determination theory, for example. These are core needs that we have. And I would ask, what are the emotions that drive these, motivate these, fulfill these needs? Under relatedness on the left, emotions like sadness and grief, tenderness and love, healthy fear, which means truly something dangerous, healthy guilt, like one truly did or didn't do something that harmed another, maybe gratitude and forgiveness. What emotion underlies autonomy or agency, protection, assertion, dominance, fighting injustice? What emotion is that? That'd be anger, which of course is on a continuum from little to large. But anger is the emotion that is needed to motivate, to propel, to meet some of these needs. And what emotions are underneath the competent self? Perhaps pride and self-compassion. In our work, we've been basically trying to help patients access, recognize, experience, and express these. And they actually sort of connect with each other. You can activate anger, and it often leads to sense of sadness and grief. We often activate self-compassion as a way to help the person motivate their access to anger. A number of ways that these could be built on, but we go after these three in our emotional expression work. And I would also add that I like this phrase, the rights of emotion. We need to target the right emotion, and oftentimes patients present a secondary or defensive emotion. They're crying when they should be angry, or they're angry when they should be feeling vulnerable or sad. The right emotion towards the right target, not displaced on some innocent person or the wall or other sort of things, but on who deserves it, and at the right intensity for the situation. In therapy sessions, more intense. In real life interactions, much less intense. A little truth in advertising, my friends. Are we really developing a new therapy? Actually, I think that most of the time, so-called new therapies are basically borrowing and building from prior therapies. Like they'll give it a little different rationale, but the rationale, the principles, techniques are often just given new labels and packaged in a new way or applied to new problems. I got to be honest, we've done some of that too. So EAET, this emotional awareness expression therapy, borrows from a lot of places. It builds on pain neuroscience education and the notion of exposing people to pain, really strongly grounded in short-term dynamic psychotherapy. It borrows some exposure therapy from CBT, a lot of emotion-focused or experiential therapy, with some additional pieces along the way. It's a composite, and I have to thank the many people who've contributed in so many ways over the years to these other forms of therapy. We've repackaged it into a new thing and applying it to chronic pain. Its basic components are: we help the patient we give them a new model, this pain neuroscience education model, a new model of the brain and pain being driven by fears. And that includes fears of their own emotions, fears of their memories, fears of interactions. We facilitate emotional disclosure. We ask them to share, to reveal some things that are troubling them, including the emotions connected with it. We engage them in an exercise we call experience expressing and releasing those emotions. Come back to that in a moment. And then we work on helping them find ways to be honest and direct in real communication. Importantly, we're always going back and forth between the emotional part and the bodily part. We have to link these emotional experiences to what's going on with their body, including changes in pain and other symptoms. This EER piece is basically, you might think of it as using an empty chair or having the person imagine talking to somebody to activate their anger and to express it in the session, to activate their tender feelings if it's somebody for whom they often could, like a family member, could feel tenderness to. I won't spend much time here, but often we'll bring in some self-compassion. Patients, when they do this work, it's very powerful. They'll often experience relief. Sometimes they'll experience guilt. They have to do some more compassion work. And eventually we want them to work towards honest, real communication and real relationships. We and some colleagues elsewhere have done over a dozen trials of EAT, and these trials vary in their control conditions and the number of sessions, for example, from 1 to 9 sessions of this work, how long we follow them up and such. I'll show you just a few of them. This is on the upper right. This is Maysa Ziadny, and below her is Jen Cardy-McIntosh. They both were doctoral students of mine, and now they're off doing their own great things. Maysa's at Stanford doing wonderful things. For their dissertations, they each did a study of a single 90-minute session. Maysa did her work directly in family medicine clinic. I believe John Porcerelli is with us here. I saw his name. He was one of the folks that mentored Maysa in the family medicine clinic. These were all patients with medically unexplained symptoms referred from the physicians. Most all of them had pain problems. They got randomized to get one 90-minute interview in the clinic versus a waitlist control. 6 weeks later, compared to the controls, those who had the 90-minute interview had lower pain severity and pain interference and sleep problems and depression and anxiety. And you can see the effect sizes there. Can you do this work in a single session? Yeah, we've actually got 4 studies now that show that a single session of this work is beneficial with very, very few sort of negative side effects. Although many patients will say, now that I've had this, I want more. Where can I get more? That's the most common thing we hear. We did a trial published back in 2017 in which we worked with fibromyalgia in a group format. This was a 3-arm trial funded by the NIH with colleagues at the University of Michigan, 230 patients, mostly women with fibromyalgia. They had 8 group sessions once a week. The groups were about 5 or 6 patients. We followed them through to 6 months later. There was an EAT arm that Howard Schubiner and I did. Dave Williams, sort of the guru of CBT for fibromyalgia, led that arm. And Dan Claw and Nancy Lockhart led an education control arm. We had therapists who were specialized, skilled, and committed to the model for each of those 3 arms, so it was sort of allegiance controlled. We found the blue line shows that the EAT group started slightly higher, but ended up significantly lower or less pain, less widespread pain than both CBT and education. And this was maintained out to 6 months. You don't often find well-done, large-scale studies done by experts with bona fide therapies like CBT, where another therapy will do better than it. We found that how many patients reached 50% pain reduction? At 6 months later, EAT had this percentage, which was significantly more than CBT. How many said they improved much or very much? Over a third, which is more than the education arm. By the way, we also tried to see whether they still met the diagnostic criteria for fibromyalgia. And 6 months later, 28% of the EAT patients no longer met diagnostic criteria, compared to only 5% of the CBTs. That doesn't mean they were completely symptom-free. There were a few, but they no longer met the full criteria for fibromyalgia. This, by the way, is Brandon Yarnes, a psychiatrist, geriatric psychiatrist at the West Los Angeles VA, and he's been doing group EAT work with older US veterans. His first study was a relatively small study. He basically randomized people to get group EAT or group CBT, 1 individual session meeting with the therapist, and then 8 sessions in the group. And he found that pain in these vets decreased more, this is the red line, substantially more than the CBT arm and maintained it out to 3 months. I'm going to jump to the next slide. He more recently just published a couple months ago a larger scale trial, which published in JAMA Open, 126 vets. And I highlighted the fact that this is not a predominantly white sample, for example. The majority were African American and mostly men with an average age of 72 years old, long-term pain problems. And he basically, again, gave them 1 session individually and 8 sessions of group EAT or CBT in person. And the outcomes here are that, again, EAT showed a substantially greater reduction in pain. There was some loss over the course of 6 months, but it was greater than CBT. If you look at the percentage of people who met certain criteria, like improved 30%, improved 50%, it was greater at post-treatment than CBT. It's still greater at 6-month follow-up on 30% reduction. I'm looking at the clock, so I'm going to jump ahead and skip a couple slides here. What have we learned about EAT? Many patients, especially those with primary pain, have some psychological contributions that we could work on. And if you help patients to experience and express those avoided adaptive emotions, can reduce their pain, probably more than CBT at this point. 3 studies are suggesting that. And there are some people who have major improvements. It's quite impressive to see the pain gone or nearly gone, or my medications are done, or all sorts of stuff. And therapy can move much more quickly to the core issues than we might fear. But there's a number of folks who don't benefit from EAT. And we're trying to figure out why. Do they have a different type of pain that's maybe less stress responsive? There's a set of people who the culture of emotional expression doesn't fit. Some are defensive or not prepared for it or too dysregulated. I would also suggest, by the way, this work is emotionally challenging for you and me and our patients. This is not particularly easy work to do. How does this all fit together? One model that Howard Schub and I put out was that we start by trying to identify primary pain and target those patients, educate neuroscience education, and work on some things that sound like it's pain reprocessing therapy, reduce the perceived danger, increase their adaptive behavior with new ways of thinking about their pain, and if needed, progress to EAT by focusing on the emotional processes and communication in real relationships. So here's a model that I'll toss out and you all can explore it. It's a hypothetical, but I'm wondering whether chronic pain that is secondary or neuropathic or nociceptive or structural might best be approached by our traditional psychological pain management approaches. Is it possible that primary or nociplastic or these other terms here, this type of pain might best be treated by these newer approaches? This is my hypothesis. It needs to be tested. By the way, this term managed chronic pain, I want to propose to you that we use this term all the time. You hear it all the time, chronic pain management. Maybe this 3-word phrase is 2/3 wrong. And what 2 words might be wrong in this 3-word phrase? Maybe it's not chronic, and maybe we don't just have to manage pain. And I ask you, what are the consequences of us telling patients, your pain is chronic, you need to live with it and manage it, or live with it despite your pain? When is that message appropriate, and when is that message possibly iatrogenic and actually causing harm or keeping people from recovering? As we psychologists do this balancing act between beneficence, benefiting people, and non-maleficence, minimizing harm, we often tend to load up on the minimizing harm side. And that makes some sense, right? I mean, if you were to fill in this phrase, our ethical imperative is first. I think I heard somebody say, do no harm. Did you say do no harm? My folks, my friends, we're psychologists. Did you know that our APA Code of Ethics says that our principle A is psychologists strive to benefit those with whom they work and take care to do no harm? It's a switch in the order, isn't it? It's not first do no harm, it's first benefit those. It's interesting to think about benefiting people as our primary goal rather than just minimizing harm. And I ask the question, what's the harm of continued pain in patients who could recover? A little plug for a study we're doing right now. We've got an ongoing clinical trial funded by the NIH to compare CBT and ACT with our PAT-EAT combination and a treatment as usual control for back and neck pain. If you have anybody out there who needs 8 sessions with a licensed psychologist done by Zoom all over the country, and 8 sessions for free, and they're paid for completing questionnaires throughout the study, they can go to paintreatmentstudy@gmail.com. And with that, I'm wrapping it up.
Thank you, Mark. That was great. Um, when I listen to your work, it just feels like this is in a different category. You know, there's a great variety of variations of cognitive and behavioral treatments, but this seems like EAT in particular is in a different category of treatments. I don't know if you think of this as being in a different category, and if so, what would you call the category?
I got to be honest, there's a part of me that hates putting people and things into categories when it's more complicated than that.
Yeah.
And we as psychologists and others continue to create a freaking load of categories for therapies and diagnoses and everything else. I'm a bit of a lumper. But it really has more roots in psychodynamic therapy and affective or experiential or emotion-focused therapies. That's all the same thing. Emotion-focused, experiential, affect focus. So there's debate, and I have people pulling me into the psychodynamic camp and others saying, oh, this is experiential therapy. The answer is yes. It's also exposure therapy. Mm-hmm. Quite honestly, I'd rather people focus on principles rather than what box their type of therapy they're conducting. And the principles here are, for many patients, especially primary pain patients, their pain can be substantially reduced or maybe eliminated when they make a shift to reducing the fears in their brain about their pain and their other fears in their life. Yeah. And if you could work in that space, you'll have a lot of success, whatever the heck you want to call it.
Okay. Okay. Thank you. Maya, do you have a question?
Beyond pain, what conditions do you think affective therapies could be particularly useful for?
I think if we look at I have a slide I didn't show you that shows all of these overlapping conditions, and not just overlapping pain conditions, of which there are many, but you can get into POTS with these, postural orthopedic POTS for these adolescents, or maybe this hypermobility syndrome stuff, which is hot right now. Lots of fatigue issues. You can do all sorts of the sort of functional syndromes, I think would sort of fit. So a lot of these somatic symptom disorders that seem to have a strong link to stress, emotions, and brain bases would probably be would be appropriate. Haven't tested that yet, so that's what I'm thinking.
Thank you.
Another question. I think most of your work, or at least the materials I've seen, are based on group treatments. And what about, for us in practice, we do almost all individual treatment. Mm-hmm. How do you adapt this to individual work? And are there manuals or other materials that are formatted for individual use?
Yeah. So it is the case. We've done a few of these trials as groups. We've also done several as individuals, and our current trial is individually done. By the way, group work is hard in EAT. Many times if you do group CBT, it's mostly an efficiency thing. I've got 10 people and I can be efficient by teaching all 10 of them at the same time. This work feels much more like group therapy, where there's processes going on among people. There's fears about revealing things. There's sometimes interactions among group members. There's overcoming the shame of revealing something to others. There's the celebration and support when somebody's able to make a move and show some growth or do some work on their pain. But it's actually pretty hard for a therapist to sort of juggle the group. It's easier to do individual work. Individually, I think it's pretty straightforward. If you have been trained in dynamic work, exposure-based work, think about giving a different pain neuroscience message, and think about helping them go towards the things they avoid emotionally and interpersonally, rather the things that are adaptive that they should go towards, rather than continue their defensive avoidance. Yeah. So manuals. On my website, if you Google my name, you'll go to my website, and I've got a bunch of materials, including a group-based manual and a patient workbook, which is free, thanks to the NIH, and some other materials for therapists and patients. We do have an individual manual right now, but I'm not disseminating it. We're using it in our therapy because the APA, our APA, asked me to write a practitioner manual. And Howard Shubin and I just got a contract like 2 hours ago, literally in my inbox, from APA saying they've approved the book proposal. And so we are currently writing a practitioner manual for EAT, which will have the individual therapy manual kind of built in there as well. So at this point, we're not able to disseminate it. And stick around for a year and a half until we get this practitioner manual published.
Yeah. And how can a clinician get trained in these treatments? Are there particular workshops or things that they can attend?
Yeah. So the pain reprocessing therapy, which is sort of split off a bit, has got quite a machine going right now. And you can just Google that and you'll find the Center for Pain Reprocessing Therapy. They hold a number of trainings for 4 weeks, including some advanced work now. Alan Gordon wrote a book called The Way Out, I believe it's called, which is sort of partly for clinicians and partly for patients, which is pretty good about PRT. For EAT, Howard Shubin and I have been running trainings, online trainings. We have one coming up in November. The wait list is long. We have probably hundreds and hundreds of people on the wait list, and we're inviting up to 100 to take it in our course. But if you go to his website, which is unlearnyourpain.com, unlearnyourpain.com, he's got some of those trainings listed for PRT as well as EAT. But I'd also encourage you to think not just how do I get training in this, but what of your basic training in exposure therapy, in psychoeducation, in tackling trauma would cover this? And I actually think people who do trauma work, if you add in the body and the pain coming from the brain as a symptom of your trauma, then you can actually reduce both trauma symptoms and pain symptoms. But you have to bring pain actively in as a symptom of the trauma.
Well, thank you, Mark. I would just have a couple minutes left. I just want to comment that I think your work is a remarkable synthesis of kind of disparate parts of the profession, ranging from behavioral and psychodynamic and neuroscience education and exposure therapy and trauma and emotional expression. It is, to use your term, a novel combination of things, and the findings are remarkable. So thank you for all your work on this, the 30 years that it took to develop this, and congratulations again on your coming award for your career service. Now, Maya, you have a few announcements to close up things.
Thank you, Dan, very much.
You're welcome.
So thank you everyone for attending the webinar today. And remember, if you'd like the CE credit for attending the event, please respond promptly to the evaluation link, which will be sent via email shortly. And we'll leave that evaluation open until Friday, September 20th at 5 p.m. Eastern. And the CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes. And thank you everyone for your 2024 and 2025 membership in SFHP. As you know, this and all virtual programs and CE credit are free benefit of membership in the Society. And you're not required to be an APA member to be a member of SFHP. So this is a very good time to invite your students, your colleagues to join and share these benefits. Anyone joining will receive benefits for the rest of this year, as well as all of 2025 at no extra charge. Just visit our website for more information, and that's societyforhealthpsychology.org. And finally, anyone who joined by phone today must contact SFHP at admin@societyforhealthpsychology.org to identify themselves so they can receive the email with the CE evaluation. And feel free to email admin@societyforhealthpsychology.org if you have any questions. And again, thank you so much, Dr. Lumley, for an amazing webinar, and thank you, members, for attending.
And be watching for our next webinar. So goodbye, everybody.
Thank you, everybody. Goodbye.